Okay, so picture this, your heart is this amazing machine, right?
Hmm.
But it has these four delicate valves, and sometimes those valves malfunction,
Yeah.
and they cause blood to flow in the wrong direction.
Right.
That's valvular heart disease.
Yeah.
It's subtle, but can have a really big impact in millions.
Stenosis has several causes,
Okay,
and where the obstruction occurs is a key piece of information.
okay.
So we categorize aortic stenosis based on whether the narrowing is above the valve, at the valve itself, or below the valve.
So you're finding the bottleneck.
Exactly, narrowing above the
Yeah,
valve,
right.
called supravalvular aortic stenosis.
Supravalvular aortic stenosis.
It's rare and often present at birth.
Okay,
Narrowing at the valve itself, valvular aortic stenosis.
okay,
That's the most common type.
got it.
And narrowing below the subvalvular aortic stenosis
Subvalve.
is often caused by a congenital abnormality called a subaortic membrane. It's like a little curtain partially blocking the exit.
Oh, okay,
So it can be a problem with the valve itself or something blocking it above or below.
okay,
So let's dive into valvular aortic stenosis a little deeper.
okay,
Congenital aortic stenosis is often caused by a bicuspid aortic valve,
okay.
where the valve has 2 leaflets instead of 3.
Right.
This can lead to stenosis either at birth or later in life as the valve becomes calcified. Think of it as a design flaw.
So the valve isn't built right.
Exactly. Rheumatic aortic stenosis, while less common than rheumatic mitral stenosis, can occur after rheumatic fever.
Okay.
The inflammation from the fever can damage the aortic valve,
Right.
leading to thickening and fusion of the leaflets.
So the same problem can affect different valves.
It can. What about aortic stenosis that isn't caused by a congenital issue or rheumatic fever?
Interesting.
There's a wear and tear process that happens as we age
Okay.
called senile degenerative aortic stenosis.
Senile degenerative aortic stenosis.
Calcium deposits build up on the valve leaflets,
Okay.
making them stiff and narrowed. It's like arthritis of the heart valve.
So arthritis of the heart.
Yeah.
Okay, but the heart is a tough organ. How does it manage with this?
The heart's remarkably adaptable.
Right.
So think about lifting weights to build muscle.
Okay.
The heart responds to that increased pressure from aortic stenosis by thickening its walls,
Okay.
particularly in the left ventricle.
Got it.
We call this concentric left ventricular hypertrophy.
Concentric left ventricular hypertrophy.
And it allows the heart to generate the extra force needed to push blood through that narrowed valve.
So it's bulking up.
It is. Are there any downsides to this?
Yeah, I'm wondering.
There are trade-offs.
Okay.
As the ventricle thickens, it also becomes stiffer,
Right.
making it harder for the heart to relax and fill with blood.
Okay.
This can lead to diastolic dysfunction
Right.
and cause symptoms like shortness of breath and fatigue, even if the valve isn't completely blocked.
So it gets stronger but less flexible.
Exactly. I was reading that this process can differ between men and women.
Oh, yeah.
You're right. Women are more likely to develop that concentric hypertrophy without their ventricle getting significantly bigger.
Okay.
This helps preserve their left ventricular function for longer,
Okay.
but they can still develop diastolic dysfunction
Right.
because that heart muscle is stiffer.
Got it.
Men, on the other hand, are more prone to developing eccentric left ventricular hypertrophy, where the ventricle not only thickens but also enlarges.
Yeah.
This enlargement increases the stress on the ventricle,
Right.
which can lead to systolic dysfunction, where the ventricle has trouble contracting and pumping effectively.
So men, a bigger, weaker ventricle, women, a smaller, stronger one.
Exactly. Does this affect the course of the disease?
Yeah, that's a good question.
It might. Women often tolerate aortic stenosis better than men in the early stages.
Really?
It's fascinating how these subtle differences in adaptation can impact the long-term consequences.
It is. It's amazing.
And it highlights how important it is to consider gender when managing aortic stenosis.
Absolutely. Now, what happens when aortic stenosis gets really severe? What symptoms do patients experience?
So there's a classic triad of symptoms:
Right.
angina,
Right.
syncope,
Okay.
and heart failure.
Got it.
These symptoms tend to develop gradually as the stenosis worsens and the heart struggles to compensate.
It's a progressive disease?
It can be. Angina or chest pain is often the first symptom,
Okay.
and it's caused by the increased oxygen demand of that enlarged left ventricle.
Right.
The coronary arteries might not be able to keep up.
Got it.
In some cases, the hypertrophy can even compress the coronary artery,
Oh, no.
making the problem worse.
Making it worse.
And of course, some patients might have underlying coronary artery disease as well.
So it's in a perfect storm.
It is. What about syncope?
Okay, so syncope.
Syncope or fainting
Right.
is another common symptom typically occurring during physical activity when the heart's working harder. So because of that obstruction, the amount of blood the heart can pump per minute is limited.
Right.
When your body needs more blood flow, like during exercise, the heart can't keep up.
Got it.
This can cause a drop in blood pressure, leading to syncope.
So it's like pushing a lot of water through a narrow pipe.
Great analogy.
What about heart failure?
That's usually a late manifestation of the disease,
Okay.
developing when the ventricle can no longer compensate for that obstruction.
Okay.
Essentially, the ventricle becomes so overworked it can't keep up. It can't contract forcefully enough, and it can't relax and fill properly.
So it's a double whammy.
Exactly. As heart failure progresses, you see symptoms like shortness of breath, fatigue, and swelling in the legs and ankles.
It's like the heart is saying, help.
Yeah, it is. It's important to remember those three symptoms. Angina, syncope, and heart failure don't always appear in the same order.
Okay.
And some patients might only experience one or two of those symptoms. The clinical presentation can vary, depending on the severity of this stenosis, the patient, and any other health issues they might have.
So there's no one-size-fits-all.
Exactly.
Now, we talked about the symptoms, but how is aortic stenosis diagnosed? What are doctors looking for?
Well, the evaluation involves a detailed history, a physical exam,
Right.
and often some additional testing
Okay.
to confirm the diagnosis and figure out how severe that blockage is. A key part of the evaluation is determining where that blockage is,
Right.
whether it's above, at, or below the valve.
So pinpointing the location.
Exactly.
Yeah.
Can the physical exam help with that?
Yeah, I'm curious.
It can. If the stenosis is above the valve, the murmur might be louder on the right side of the chest
Oh, yeah.
because the blood flow patterns are different in supravalvular stenosis.
Right.
Feeling the pulse in the neck, the carotid pulse, is also helpful.
How so?
Well, in valvular aortic stenosis, the carotid pulse is weak and has a delayed upstroke because it's harder for blood to get out of the ventricle.
Makes sense.
This helps us differentiate between valvular aortic stenosis and other conditions like hypertrophic cardiomyopathy or HOCM.
How does HOCM differ?
The carotid pulse in HOCM is much more forceful
Okay.
because the obstruction changes throughout systole.
Right.
It's a dynamic obstruction, not a fixed one like in valvular aortic stenosis.
So listening to those heart sounds is really important.
Absolutely. In severe aortic stenosis, the aortic component of the second heart sound A2 is often soft or even absent.
Wow.
Because those thickened valve leaflets don't close properly.
Okay.
The slitting of S2 can also tell us something.
What are we listening for there?
So in mild to moderate aortic stenosis, the splitting of S2 is usually normal.
Okay.
But when the stenosis is severe, that splitting may be narrowed or even paradoxical.
Paradoxical.
Where the pulmonary valve closes before the aortic valve.
Interesting.
This happens because that narrowed aortic valve increases the pressure in the left ventricle,
Right.
delaying the closure of the aortic valve.
It's amazing how all these little clues fit together.
It is. What about that fourth heart sound, S4?
Okay.
It's often present in aortic stenosis.
Right.
And it tells us that the left ventricle is stiff
Okay.
and isn't relaxing properly. It's a sign the ventricle is working hard but struggling.
So working overtime, but not efficiently.
That's a good way to put it.
Yeah.
And then, of course, there's the murmur.
The key finding.
Exactly. So the classic murmur of aortic stenosis starts softly, gets louder, and then fades before the second heart sound.
Okay.
We call it a crescendo decrescendo systolic ejection murmur.
Crescendo decrescendo systolic ejection murmur.
It's typically loudest in the aortic area,
Okay.
the second intercostal space to the right of the sternum,
Got it.
and it often radiates to the carotid arteries in the neck.
So traveling upwards?
It is. So the murmur is giving us information about the location
Right.
and the severity of the stenosis.
And makes sense. The later the peak, the more severe.
Yes, exactly, because it means that pressure gradient across the valve is higher,
Okay.
and the sound of the murmur itself can be helpful.
How's?
Aortic stenosis murmurs tend to be rough and harsh, sometimes described as grunting.
Not a pretty sound. What about the Gallavardin phenomenon?
Ah, yes.
Okay.
The Gallavardin phenomenon is when the murmur has a high-pitched, almost musical quality,
Okay.
and is heard best at the apex of the heart.
Interesting.
It can be mistaken for the murmur of mitral regurgitation.
Why does that happen?
It's like an acoustic illusion.
Okay.
It's caused by the turbulence of the blood exiting the narrowed valve,
Right.
creating vibrations in the nearby mitral valve leaflet.
Interesting.
This creates that high-pitched musical sound.
Wow. So one valve problem can create so many different sounds.
It can. Now, are there times when the severity of aortic stenosis might be underestimated?
I'm sure there are.
Yes, there are a few situations where that can happen.
Right.
For example, if aortic stenosis exists alongside other valve issues,
Okay.
like mitral stenosis or pulmonary hypertension,
Right.
those conditions can make the aortic stenosis murmur softer,
Oh, interesting.
masking the severity. It's as if those other valve problems create a traffic jam,
Right.
reducing the flow through the aortic valve. Another situation where it can be tricky is in elderly patients.
Okay. Why is that?
Well, the classic symptoms of aortic stenosis, angina, syncope, and heart failure,
Right.
can be mistaken for other age-related conditions.
Okay.
This can delay the diagnosis.
So it's important to be aware of it.
Absolutely. And high blood pressure or hypertension can make things tricky too.
How so?
Well, hypertension makes the heart work harder,
Right.
which can intensify the murmur of aortic stenosis
Okay.
and lead to an overestimation of its severity.
So it adds extra strain.
Exactly. We need to be mindful of all these factors when evaluating a patient with suspected aortic stenosis. It's about seeing the whole picture,
The whole picture.
not just focusing on a single finding.
Okay, that makes sense. Let's move on to aortic regurgitation.
Okay.
So instead of a narrowing, now we're talking about a leaky aortic valve where blood flows back into the left ventricle during diastole. What are the usual culprits behind this condition?
Well, aortic regurgitation can result from problems with the valve leaflets themselves
Oh.
or from dilation of the aortic root,
Okay.
which is the part of the aorta just above the valve.
Got it.
Think of it this way. If the leaflets are damaged, they can't seal properly, and if the aortic root's dilated,
Okay.
it's like the foundation of the valve is stretched out,
Right.
also preventing a proper seal.
So what kinds of things damage those leaflets?
Things like rheumatic heart disease, endocarditis, and congenital abnormalities like a bicuspid aortic valve
Right.
can all affect those leaflets.
So similar causes to aortic stenosis.
Yeah, just with different effects on the valve.
Okay, so for example, with rheumatic heart disease,
Yeah,
the inflammation scars the leaflets,
exactly.
making them thick, short, and retracted,
It does. They just can't close properly.
so they can't close.
And endocarditis, remember,
Right.
is an infection that can damage the leaflets,
Okay.
creating holes or growths that interfere with their function.
So they can't work.
Right. Bicuspid aortic valves are more prone to leaking because of that abnormal structure.
So many things can go wrong. What about dilation of the aortic root? What causes that?
High blood pressure is a common cause.
Okay.
Also, Marfan syndrome, a connective tissue disorder
Oh,
that weakens the walls of the aorta,
right.
and syphilis, a bacterial infection that can damage the aorta.
So many different causes.
There are.
Yeah.
So that support structure for the valve is weakened or stretched, and it can't close properly.
Right. And we also see aortic regurgitation in cases of trauma,
Yes.
dissection of the aorta,
Right.
and certain inflammatory conditions like Takayasu's arteritis.
Exactly. It's incredible how many different things can lead to a leaky aortic valve.
It is. And
I'm-
thankfully, we have echocardiography,
Yes.
which allows us to visualize the valve and the aorta
Right.
to help us figure out the cause.
Exactly. Now, you mentioned earlier the heart's really good at compensating for problems.
Yes.
How does it adapt to aortic regurgitation? Well, the heart's main way of coping with aortic regurgitation is to enlarge that left ventricle.
Okay.
As blood leaks back into the ventricle, it needs to accommodate that extra volume. It's like a balloon expanding to hold more air.
So making more space.
Yes. This enlargement allows the ventricle to maintain a relatively normal ejection fraction,
Right.
which means it's still pumping out a good percentage of the blood it contains,
Right.
even though it's getting more than usual.
So working harder, but still managing.
Yeah.
But are there any long-term consequences to this?
Unfortunately, over time, this chronic volume overload can damage the heart muscle.
Oh, no.
As the ventricle stretches, it has to work harder to generate the same amount of force.
Oh.
It's like stretching a rubber band too far.
Right.
Eventually, it loses its elasticity and snaps.
Wow. So it's working harder, but getting weaker.
Exactly. What happens then? Eventually, this can lead to left ventricular dysfunction.
Right.
The ventricle can't pump as effectively,
Okay.
and the regurgitation can worsen. It's a vicious cycle.
So catching it early is key.
Absolutely. Now, how do the symptoms and signs of aortic regurgitation differ from aortic stenosis?
Right.
What do doctors look for?
Yeah, that's a good question.
Well, the presentation of aortic regurgitation can vary greatly depending on how severe it is, how quickly it developed, and the individual patient.
Of course.
Some patients might not have any symptoms for years, while others may develop symptoms early on.
So it can be silent.
It can. Unfortunately, sometimes by the time symptoms appear, the regurgitation is already severe,
Oh, wow.
and the heart is struggling to function.
That's scary. What symptoms might patients experience?
Well, fatigue is common.
Okay.
as well as shortness of breath and palpitations.
Makes sense.
The fatigue is because of decreased cardiac output. The body isn't getting enough oxygen-rich blood.
So it's not delivering.
Exactly. What about the shortness of breath? That's caused by the blood backing up into the left atrium and lungs, leading to congestion and fluid buildup.
So similar to mitral stenosis, just a different valve.
Exactly. And those palpitations, the awareness of the heartbeat, are often due to the forceful contractions of that enlarged left ventricle.
Okay.
Some patients also experience angina, especially at night or during exertion.
Interesting.
Yeah.
Why would someone with aortic regurgitation experience angina?
There are a few reasons.
Okay.
The enlarged left ventricle demands more oxygen,
Right.
but it might not get enough.
Okay.
Also, the diastolic blood pressure in the aorta can be lower,
Right.
reducing blood flow to the coronary arteries that supply the heart muscle itself.
Right.
And as we talked about before, some patients might have underlying coronary artery disease.
Okay. So a lot to contend with.
What about the physical exam? What clues point to aortic regurgitation?
I'm listening.
A key finding is a wide pulse pressure.
Okay.
The difference between the systolic and diastolic blood pressures?
Right.
In aortic regurgitation, the systolic pressure is often high because of that large volume of blood being pumped out.
Okay.
But the diastolic pressure is low because of the leak.
So high peak, low valley.
That's a great way to put it. We can detect this wide pulse pressure by measuring the blood pressure
Right.
and by feeling the pulses.
Okay.
Aortic regurgitation also has several peripheral signs related to that larger stroke volume,
Okay.
the amount of blood ejected with each heartbeat,
Got it.
and that rapid runoff of blood from the aorta.
So the blood is really surging.
It is, and this can lead to some noticeable signs. For example, the Corrigan pulse,
Okay.
also known as a water hammer pulse.
Water hammer pulse.
It's a bounding, forceful pulse that collapses quickly
Got it.
because of that blood flowing back into the ventricle.
Like a wave crashing and receding.
Exactly. What other signs might be present? We have de Rosiers' sign, which is a murmur heard over the femoral artery in the leg when it's compressed.
Interesting.
And Hill's sign,
Okay.
where the systolic blood pressure is higher in the leg than in the arm.
So the force is more noticeable in the legs.
Right. We might even see visible signs like head bobbing with each heartbeat. And we can sometimes see the blanching and flushing of the fingernails with each heartbeat,
Okay.
called capillary pulsations.
So many different signs. What about the heart itself?
The apical impulse is often shifted downward and to the left.
Okay.
Because of that enlarged ventricle. We might also feel a systolic thrill over the area of the chest overlying the heart.
So the heart's taking up more space.
Exactly.
Yeah,
Listening to the heart sounds is also key.
of course.
The first heart sound, S1,
Okay.
might be soft or normal.
Got it.
The second heart sound, S2, may be split,
Okay.
and you might hear an S3,
Right.
that low-pitched sound indicating rapid ventricular filling.
Okay.
And then there's the murmur.
The defining feature.
It is. So the murmur of aortic regurgitation is a high-pitched, blowing diastolic murmur,
Okay.
heard best along the left sternal border.
Got it.
It usually starts right after the aortic valve closes,
Okay.
and its duration and intensity tell us how severe the regurgitation is.
So it's a whooshing after the second sound.
Exactly. And depending on which way that blood's flowing, it might radiate to the apex of the heart or to the right sternal border.
Now, I remember reading about the Austin Flint murmur.
Ah, yes.
Okay.
The Austin Flint murmur is interesting. It's a low-pitched, rumbling diastolic murmur heard at the apex of the heart.
Okay.
But it sounds like the murmur of mitral stenosis.
So confusing.
It can be.
Why does that happen?
Well, we think it's caused by that leaking blood from the aortic valve hitting the anterior mitral valve leaflet,
Okay.
creating a sort of functional mitral stenosis.
So it's creating a blockage.
That's a great way to think about it. And the presence of an Austin Flint murmur usually means the aortic regurgitation is severe.
Wow. So we've covered mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. But what happens if someone has more than one valve problem?
Multiple valve problems or multivalvular disease definitely adds another layer of complexity.
I bet.
The presence of one valve problem can affect the blood flow patterns of other valves.
Right.
It can be tricky to figure out how severe each individual problem is.
It's like a puzzle where the pieces are moving.
That's a great way to put it.
Right.
So, for example, if someone has both mitral stenosis and aortic regurgitation,
Okay.
the mitral stenosis might make the aortic regurgitation seem less severe than it actually is.
Interesting.
This is because the mitral stenosis reduces the amount of blood flowing to the left ventricle,
Right.
which in turn reduces the amount of blood leaking back through the aortic valve.
So one problem masks the other.
Exactly.
Okay.
Are there any other examples?
I'm sure.
Of course.
Yeah.
Think about the opposite scenario.
Yeah.
The aortic regurgitation can make the symptoms of mitral stenosis worse, even if the mitral valve isn't severely narrowed.
Interesting.
This happens because the aortic regurgitation makes the left ventricle work harder,
Right.
which can worsen those symptoms of mitral stenosis.
So a domino effect.
Exactly. And this interplay makes it really hard to use the standard formulas and techniques we normally rely on
Okay.
to assess individual valve problems.
So it's more of an art than a science.
You could say that we need a thorough history, a detailed physical exam, and careful interpretation of the echocardiogram to assess the severity of each valve problem accurately.
It's like detective work.
You're exactly right.
Yeah.
And it often requires a team of experts,
Okay.
cardiologists, cardiac surgeons, and other specialists to develop a personalized treatment plan for each patient.
So teamwork is key.
Absolutely.
This has been an incredible deep dive into the world of valvular heart disease. I feel like I've learned so much.
It's been my pleasure exploring this fascinating topic with you.
And a huge thanks again to London Heartbeat's Z Academy for providing the amazing material for this deep dive.
They're a fantastic resource.
Remember to subscribe to London Heartbeat Z Academy on Facebook, Instagram, Spotify, and YouTube to keep your cardiology knowledge up to date.
Absolutely.
And don't miss out on any future discussions like this one.
You won't regret it.
Thanks for joining us on this deep dive into valvular heart disease. Until next time, keep those hearts healthy and those minds curious.